Day to day, we have a community support services entity that provides the care. I only see people once every 2 weeks, and I see them in a group. So the court in our county is pretty uninvolved day to day.
So I have a weekly docket that's at a set time that's right after my civil commitment docket, and that's where I hear either reviews or new petitions or repetitions. So I do have a set weekly docket in the AOT program. And I have the public defender there, the district attorney, and the AOT director and the treatment provider.
And judges, from what I've seen jurisdictionally, is that one of the beauties of AOT is that really a judge can set it up to tailor their time demands. In some jurisdictions, judges will have staff meet with the individuals or providers on a daily basis or weekly basis. And the judge only comes in when someone's doing poorly for that black robe effect. They'll take them to the court when the judge can visit them. Some judges, like ourselves in San Antonio, we actually prefer to be part of that weekly staffing, much like a therapeutic drug court.
Treatment team. You meet with the treatment team.
We put a little hiatus on it for the moment for other reasons, but the way it works best for us for the last decade has been in our court. The judge will go spend some time in an afternoon. I'll have one afternoon a week where we will go to the clinic where they provide services. And again, in Bexar County, we're lucky because it's a unique jurisdiction. The whole county is in one city, in one jurisdictional area. A lot of people don't get that luxury. So I will travel to the clinic where they get services, and we'll have our staffing in one of their conference rooms. But I guess what shouldn't be lost is that's the beauty of AOT. Every judge can set it up in a way that they think best.
I agree, but do you do your treatment team and then you have the patient with you and you have that conversation with the patient at that moment?
Correct.
And then you do your civil commitment, so people could be civilly committed in the morning and then see you in the afternoon as part of a review?
So, I have a civil commitment docket, and then I have the AOT docket, which is separate. And I don't see every AOT participant, it's need basis.
Okay.
And so if I commit them at 9, I most likely would not be committing them on an inpatient status if I'm moving them to the AOT docket. So I'll still probably only see them once.
Do you only see them when you're committing them, or do you see them along the way to keep them from failing?
It depends. It depends what's appropriate for the participant. Some of these participants, as you know, have very high anxiety with coming to court. So I probably would not see them as much unless they're having issues. So sometimes I see a participant once. I have a participant right now I see weekly because we're dealing with a substance abuse issue right now. It's co-occurring. So it just is participant dependent.
And those are tough, those co-occurring.
Well, I don't think we have the answer on that one.
Yeah.
Not in our section. I see people in groups. So every 2 weeks, if you're civilly committed, you're going to see me at least once every 2 weeks initially, and then once every 4 weeks or 6 weeks or 12 weeks.
And you bring them in as a whole group at once?
Bring them in as a whole group, so they get to hear the people who are doing well, the people who are struggling, get to see that there are peers who are doing really well, and then the new people go last. So it's much more like a criminal mental health court docket.
Like a specialty court docket.
Exactly.
Right. And amazingly, when Judge, you and I have had this conversation before, some of the best AOT judges originally cut their teeth on drug courts. And the model for an AOT in many ways echoes that drug court. I mean,
Ours certainly does,
yeah.
almost precisely. It's the same as a drug court or a mental health court. But part of that's funding. In our county, that's what we can afford to do. We couldn't afford to do what you do, where I met with the treatment team and saw people
once
weekly.
a week. Yeah.
I don't know that we could get the treatment team assembled. That in and of itself would be very expensive for our court, even if I went to the place where they were getting the treatment. So very different.
Is it your experiences? I mean, I've had the chance to do both. I've done, I'll go to the clinic where we meet them on an individual basis, and then I've had them also come to court. And each one's got their strengths and weaknesses. I agree with you. Bringing them to court can be quite intimidating. At the same time, though, sometimes that's what's needed. I mean, you need that aura of a court, of a judge in a black robe saying, Jimmy, you really better do good or else, this is going to happen, and, we really want you to succeed. Equally, I find that meeting them on a regular basis in an intimate environment gets you to know the patient much better and the patient to know your expectations. And they almost feel as though they don't want to let you down once they get to know you. I mean, I don't know if you get that experience as well.
Well, I certainly think that's an important part of what we do, that feeling that we are supportive and kind and, we want them to be successful. I think we can transmit that in a large group, but I never have had the opportunity to do what you do. It's much more like what you do, where you have people come in, high anxiety people we let come later or earlier. They stand outside, they're brought in when they're ready to come in. Although I will tell you that we've had the great experience of watching some of them as their anxiety diminishes, they get more accustomed to the program. They can come in, they can sit, they can participate a little bit more. So we consider that a win, that they've come to a place that they were formerly uncomfortable and now they're able to participate. So it's a little bit different.
Do you get written reports when
Both.
you see? Okay, so you get written and verbal.
Right.
Okay, because I just get verbal for the reviews, but for petitions, that's all written pleadings that are filed in. Is that similar?
We do. It's interesting. It's so different. We have civil commitments that take place in the hospitals, and I don't do that on purpose. I have magistrates who go and do the civil commitments because I want there to be a separation between the people who put you in and the people who are helping you stay out. So,
Interesting.
well,
Because I have both.
do you?
Because of our resources.
And I do it like you do it. I do
Right.
both. So I will be a person who can commit you. However, here recently, I've been shifting over to your model where I send magistrates and associate judges to do most of the hearings, and I'll still do some of the hearings. It'll be interesting to see if that's the effect for us.
Well, I can give you some comfort because when we did the mental health court here in Ohio, we were studied from the beginning, and we discovered that the black robe effect is pretty valuable even in groups.
Okay.
So if you try it that way, where you're bringing in other people, you're having, you don't have to have the personal contact, you can still get a lot of the same effect, I think.
Do you find any issue with talking to Jimmy about his schizophrenia and his voices, and then Sally about her anxiety in front of a group?
I don't have any problem with that personally. Do they have a problem? I don't know. Do you have your people come in as a group or one by
They
one?
come in one by one,
Okay.
mainly because they're confidential cases, and so we've just had them separated. And then it's more of an open discourse in that regard because they're not talking in front of their peers. I don't know if that's the better model, but that's just what we do.
You know,
I think they both work, to be honest.
I
with
can
you.
tell you, it's been interesting sometimes to see people who come up who are really floridly psychotic and who are talking about all, snakes in the room or whatever, and to have other people come up after them and go, wow, there's something really wrong with him. And then you can say, he doesn't think so. He doesn't think there's anything wrong, and he doesn't understand that he keeps going to the hospital because he won't take his medicine. What's your response to that?
Right.
And it's been very interesting to watch people go, maybe I need to think about that.
Yeah,
So
maybe-
that's why we like the group. I view the group as sort of a therapeutic modality that we can use.
makes sense.
But also, we just don't have the funding to do separate, and we have too many people to do, even if we did like a call day where they came in one by one, we just have too many people.
So our peers interact with social activities. So we have we have several social activities, and then we have the groups where the peers come together. We also have family nights.
That's great.
Once a month, because really we try to draw on the family members that have been supportive or maybe were and maybe are willing to be supportive again with our intervention. So that has been great. And we've also had our graduates come back as peer mentors to those social events because research has shown that peer mentoring has really assisted in success rates for specialty courts.
Do you do that through your court? Are those social activities set through the court?
So it's through the AOT team.
Okay.
So it is through our program.
And who does does your court system fund the AOT team, or does the provider system fund the
We
AOT
have
team?
a SAMHSA grant currently and partial state funding. But the good news is, because our program has done very well, our Department of Human Health Services is going to add our SAMHSA grant funding to the state budget.
Oh, wow.
So hopefully in another year we'll be part of a state budget when the SAMHSA grant runs.
Very nice.
So, right, right. Well, and it's interesting because down south in Clark County, where Las Vegas is, they were state funded to begin with. And so then in the north, we had to get the SAMHSA grant and through a demonstration project, but it's been great and successful. So the good news is I believe we're going to get funded as long as the governor signs on that budget.
So I know you're going to get somebody who's going to be watching this conversation, some judge, will look at this and say, well, of course, look at the money they're getting. We don't have that kind of money. And it's good for people to know that we don't operate on a grant ourselves. We plug it into the very same docket we already had with the very same lawyers we already had when it was commitment. So the extra expense, and there is some extra expense that comes to the court, is the judge having to take a portion of a day off to take care of it. We did have to have at least one position that in our case is funded by the provider, believe it or not, because they're so, our local provider is.
Is that a monitor? How would you, what would
Yeah,
you
we call it
that
a
person?
liaison officer.
Okay, liaison.
And then,
okay.
and then the original, of course, we started this thing 10 years ago before there were any of these things around, 10 or more years ago. And the original concept was, since we didn't have money, we didn't have granting, and interestingly, we couldn't apply for granting since we were the first court in Texas. You couldn't already be a court to get grants.
Right.
So we cut our teeth.
No, we had that problem.
I was like, come on, man, we did all the work. So interestingly enough, where was I? What was I saying right then?
About
About
the
the
funding.
funding.
Oh,
for your
yeah,
monitor.
yeah. So interestingly enough, when you look at it, we viewed it as judge plus ACT team. So in most jurisdictions in Texas, an assertive community treatment team has to service would have to service these people anyway if they came in voluntarily, some county entity or some public entity. So we just added the judge component to it. The DA and the lawyers show up for the hearing as part of their duties if you're in the mental health court.
For the civil commitment itself,
the
the
civil
original
commitment, yeah, for the original commitment.
And that's
And-
true for yours. You don't have lawyers for the status hearings, do you?
Actually, they do show up.
Yeah, we-
and it's
we-
the
we do as well.
same- And
Do
it's,
you
and it's the
really?
same attorneys that do the civil commitment
Same
docket.
for us.
And they have been very supportive of the AOT program because for the defense attorney, it's getting their client out of the hospital. For the prosecutor, it's definitely the community benefit of, they're not in jail, they're not in the hospital. So we're fortunate that all the stakeholders have been supportive and interested.
Do your defense attorneys stand with patients? Oh, really? We don't have any lawyers in
See,
the room.
but
so-
you're an excellent, and again, when somebody watches these conversations, it's the beauty of AOT. You can set it up to
Oh,
work
I
for
agree.
you,
Yeah,
and
I
you're the
agree.
beauty of showing people who are watching this.
I have the cheap one.
Yeah,
I
I mean,
have
you
the
can- you
cheapest
can do
program
it.
you can have. I do. We had AOT for 20 years. We were civilly committed, and we had developed a robust community support system around keeping the patients out of the hospital. But it wasn't as beneficial to them as it turns out to be when you add the judge component.
Right.
So we had a system that was set up, but we didn't have the judge component. So what we've added is the judge component, and that's donated time like yours is or yours is. And then we had to hire a monitor who is the liaison who
Right,
collects
and that's
all
what we
the
did.
data for me. And
Well, our monitor does a little bit more. Our monitor coordinates between what the providers, what the
Oh, yes,
counselors are doing,
absolutely.
and they
Yes.
report to us. But I got to tell you, I mean, you've been doing, to give you kudos, I mean, you've been, I think we had this discussion at another jurisdiction. You cut your teeth on this before any of us were. I mean, you've been doing this for quite some time, so.
well, our county has been, yeah. But the nice thing is we had a system that was in place. The bad thing is that if you already have a system in place and you come in as a judge and you say, gee, could we do this? They go, no, the system's in place. On the other hand, I mean, really, we had no expense. And for the first 2 years, I had a person who was kind of a part-time volunteer to be the liaison/monitor. And then we eventually had to hire a full-time person. I'm not sure that she will stay full-time as we go forward, but you definitely need to have somebody who can, liaise with these providers to get the information. So I get
right.
written information, and then a case manager, who's the person who stands up with my patient is the case manager, not a lawyer.
We do it at a table, but it's the same thing. Since
Yeah.
we do it at the clinic, it'll be the patient. I mean, it's the most important part. It'll be the patient, the judge, and it's a round table. Knights of the round table. With the patient, the judge. We'll have the defense attorney and the prosecutor there, who are there, by the way, again, as part of just their duties in that position. We're lucky because we have a public defender's office
Okay.
that we can ask that they make that part of their duties. But
Do you have that too, or do you have to
Yes,
pay
yes, it's
privately?
a public
Yeah,
defense.
see, we
Yeah,
pay
that- yeah.
privately.
Right, and that's how you kind of judge. And again, this is a good example of how every judge
So it'd
can
be very
juggle.
expensive
Right.
to have lawyers coming in and doing that.
So they sit there, and the caseworker comes in, and the liaison officer is there. And sometimes, for some time there, until we had a shortage, we had the doctor would actually come in from the clinic, would actually sit. He had become so vested in the program that he would come in whenever that individual was there. Since we held our hearings at the clinic, we did that because, so for example, so you're not taking your meds. I want to encourage you to take your meds. We get to a point where the guy says, okay, I'll take my meds. All right, well, doctor's right across the hall. And it seemed to be a benefit. Also, it's a good way to get them there to get to services under the auspices of, I got to go see the judge. Well, while you're here, let's make sure you take care of your services.
Well, that would be ideal. I will say the case managers can take them. So if you have to choose between lawyers, if you're in a program where you're trying to make a decision, the case management has worked out really well
Yeah.
because they can then transport immediately after court, directly to wherever they need to
So
go.
are your hearings in the court?
In the court,
Okay, and you're at the hospital.
A little bit of both. We all take deep breaths at this point.
You know, how do you address non-adherence? It's so different for each person. That's my opinion. You're really going to be a life coach for each person as they appear before you. So each person needs a different type of motivation. Although for us, the overarching motivation is, hey, you don't want to go to the hospital, do you? It's not like a drug court or a mental health court. You can say, hey, you're looking at one day in jail, you're going to do community service. It's, at
Right.
least for us, that's all we have is we're trying to keep you out of the
Right.
hospital.
So I think one is, I have this one person that we're working on is co-occurring. So he's coming to court every week. Similar to a drug court, positive incentive is to not come to court so often. And then it's just the encouraging, like you say, because I definitely think every time you're seeing this person, you're encouraging them to do well, you're encouraging them to say, every time you use methamphetamine, that's a felony, you could be arrested, you could be in jail. So you talk about the negative consequences, but that's really the most you can do aside from encouraging.
And I think the most important part of putting together an AOT and following along with adherence is having the right type of person in AOT. AOT, when you first start it, is not the place to put an individual who's been in and out of jail 10 times. It is not the place usually to put an individual who goes to the hospital so often through their lives that the threat of the hospital isn't a threat at all. You've got to kind of find that Goldilocks zone. You're looking for that individual who's a high utilizer, but isn't brand new to the system, but the kind of that in-between individual who's about to cross over into not really caring what you have to say about or what you have to give them.
We take everybody.
Yeah, we try.
We
but
take everybody.
We try,
Me too.
but just it's tough for us because if for example we in Bexar County, we don't have drug treatment centers that can address the dual diagnosis, that I can order them to or that they can go to or that's funded. So how do I get a guy who's meth addicted to follow and stay on his medications when even the threat of going to jail after he's been there 4 or 5 times means nothing to them? So at the same time, you don't want softball patients who are going to succeed anyway. They shouldn't be on AOT. They can. We all agree if they can do it, they should be able to do it on their own. I think we're trying to find that middle ground, that percentage of individuals who need that authority figure.
But see, you have to do that because the way your program's set
Right,
up. I think
correct.
that the black robe effect is the quality for adherence. I mean, the fact that you come in and you see people, and I wear a robe and I'm in a court, everybody understands what that is. Doesn't matter how psychotic you are, you're in a courtroom, I think. So I think there is a real benefit to having a judge say, look, you can do this, I believe in you.
I agree.
But there is a value, if you do the large group, to having people who are going to be very successful. And we do. First-timers in the program, it's important for them, in my opinion, even though they're probably going to be successful with AOT, is that they see that there is a system of support. That should they require assistance in the future, they don't have to wait till they're really, really sick. They now know there's a system in place and that our goal is to help them, stay out of the hospital. And I think that can make a difference. In our program, which does take everybody, we only have had, in 3 years, about 16 people get recommitted after they finish the program. And of those, about half of them, when they come into the court, no matter if they were a short time, first time, whatever, I say, what brings you back? I stopped taking my medicine. Well, to me, that's a win, right?
Yeah,
That's
'cause
a
they're
win.
telling you.
Yes.
Yeah.
So over the long haul, I do think that adherence comes from having a judge tell you you're doing a great job, and then seeing that you're staying out of the hospital and understanding that there is a system. But
You know, one of the things that we found, in particular, when we're trying to get people into the program, in Bexar County anyway, is that without all the other components in place, it's a much more difficult prospect. That is, you know, you've got to be able to lead them to housing. You've got to
Oh,
be
sure.
able
And you
to
do
lead
that
them
too,
to drug
right?
treatment. At least, and if we can't, for example, if we can't give it to them, at least be the focal point to get them there to the service that's available out there. You know.
So that discussion helps too. And part of it is really just telling them the negative consequences if you continue
Right.
down this road.
well, that's the thing too that I like about mine, and you know, obviously I'm invested in my own program, but they do get to see people getting negative
It's a
consequences.
good program.
They also do get to see people getting rewards. We have movie tickets or come to court less or, you know, different kinds of opportunities. But they do get to see people who you're saying, look, you're going to go right now.
What's your criteria? I mean, and so in Texas, our criteria, I know they all echo each other across the country, but our criteria very much says that it's got to be an individual who, without benefit of the program, would not likely succeed and would not adhere to treatment. So that makes it a little difficult for us in Texas to get those first timers in, unless they're so ill in their first contact that the doctor can testify to that. In our jurisdiction, it's a little tougher to get those individuals in early on. In other jurisdictions,
It's danger to self or others.
Yeah.
Plus, then there's another category of you're not going to comply. But
Yeah.
we meet most people because they become a danger to themselves or others,
Yeah,
usually to themselves.
Ours is that 3-part, but that not likely to comply is probably a little beefier. It restricts who we can get in.
So our statute requires either prior hospitalizations or prior incarcerations, and so actually ours is quite targeted towards severely mentally ill. So our success rate has been varied. What has been constant, though, is while they've been in the program, we have kept them out of the hospital and out of the jail. So it's been significant. I think our biggest challenge is post-program, making sure they maintain their outpatient treatment and see that value, which is what I really think the AOT program is about, is having them appreciate the value of continuing their outpatient. Wasn't it so nice not to be in the hospital or the jail for the past year? And hopefully.
How long is your program? How long do they
So
need for?
our statute only allows orders for up to 6 months, and normally we repetition then for another
Okay.
6 months. I think the average length of stay has been at least a year to 18 months. I really think, though, a lot of our individuals could stay lifelong because
true.
they could really use that lifelong support. So I think once we're state funded, we might be wanting to keep certain individuals in lifelong. And it's interesting because some who have graduated, it's almost been bittersweet because I don't think they've wanted to leave.
Right, they want to come back.
They want to come back.
We've had that. They say, can I come and visit you? It's
Right.
like, well, sure.
They have
sure,
really
visit.
connected with their psychiatric caseworker.
Yeah.
They don't do well with change. So here we are forcing this change and this transition. And so they love their diploma. They kiss it. I mean, it's
Yeah, they'll
it's
hug you. They
beautiful.
love it.
Yeah,
They'll
it's
cry, you know.
beautiful. But it's almost like they don't want to leave, and you're pushing them out of this nest and hoping they'll fly.
Which is kind of the objective. I mean, we're trying to
Right.
get them to the point that they accept wellness as their pattern instead of illness.
Well, I think if this is for judges, to hear people say, I don't want to leave you, Judge, would be one of those very unusual moments in most of our life.
that we don't even hear from our own children. Perhaps.
Yeah, exactly. I want to come and visit.
How do you define the levels of successes in your programs? Because I think we have 3. Ours is, you know, I always tell the caseworkers, you know, we kind of have 3 levels of successes. We've got the monitoring case. So that's the case that we know they're going to fail. We know they're not going to succeed. We know they're going to get ill. We know we're going to have to put a whole bunch of resources in it, and they're probably not even going to listen to us. But at least we have them on the radar instead of off the radar. So we're providing services as opposed to finding them 6 months down the road and ill and in jail or The second one is the period services, success. And that is, while they're on the program, we talked about this earlier, they didn't go to a hospital. We kept them on their meds. We got them their driver's license, and somebody took them to the Social Security office. And, we were really able to intervene in their lives during that 6 months to a year or more that they've been on from 90 days to a year or more that they've been on the program. And then the third one, and we've all experienced this, is the home run. It's that patient that was in and out of a hospital, and they finally learn to cope with and understand the condition they have, and everything falls in place for them: housing and family and wellness. Those are kind of the three. Right. The ones we're going to fail, but we got them. The ones that we're going to monitor and keep them well while they're there, and then the home runs.
We have the exact same 3 levels. So another important thing I would mention to judges who are just starting program is to start your statistics from the get-go.
Oh, that's true.
Connect with your IT department at the court so that you can track. It's so much easier to get that information, set your criteria to know what statistics you want, especially if you want to then get state funding, if you get seed money and you need to have sustainability. Those statistics are really important. So that was just one, and my IT department loves me because we did this from the get-go versus them coming in later and needing to recapture information from a year ago. So that is just actually one important tip I wanted to mention.
And you need to decide what you're going to capture, because we didn't capture a lot of things that people now tell us are important. I mean, we were capturing basic things, but not necessarily where you lived, which turns out to be significant in my county, which is big and has many jurisdictions, where you started from. So
right, and
they
I
need
think
to make sure they're talking to the stakeholders about what it is that they think they're going to need.
Right, and I think you get some guidance from your specialty court statistics, also
Yes.
from guardianship statistics. There were some things that guardianships
Correct.
captured that specialty courts didn't, that actually apply to this group of participants.
Yeah, we initially started just looking at the Center for Healthcare Services, which is our provider, and doing a wonderful job. Again, we're lucky. All of our jurisdictions is within one county. That's how big the metropolis is. But we essentially just tracked the number of admissions or hospitalizations or jail visits the year before the program, the year of the program, and the year after the program.
Yes.
But it turns out that there's this whole cadre of individuals that have stayed healthy for 5 years out, and we lost a lot of that data because we weren't tracking after that first year. And every day out of a bed is $1,000 that saves the community is saved
Right.
for each individual.
What I love to track, which is difficult, is ER visits.
Yeah.
That's
because
true.
That is
they're
tough.
also part of that revolving door. So you can track your hospitalizations, you can track your incarcerations, but it's really difficult to track those ER visits, although those are the top 3 of our high utilizers where they go. And that ER visit is also quite expensive.
Oh, absolutely.
So these are all staggering money amounts that judges can use to show the cost savings. And for this, nominal cost to run the program, these are the huge cost savings you get.
Did you come up with a solution on the ER visits?
No, not really.
Because we're trying to track them, and it's anecdotal. I mean,
It's
sometimes
hard.
we find
Right.
out, sometimes we don't.
Right, exactly, and that's the same for us. Very anecdotal. It's a hand count, which is not ideal.
And even if you come up with a system where you can alert them, if Johnny walks through the door, let us know, call us, or track it, or this is a list of the individuals we want you to look for. The ERs themselves have such a turnover rate. The doctors are coming in and out. The staff is coming in and out.
Right.
So it's. I will say that if you put a lot of effort into that task, it's probably effort you could use somewhere else.
But you know what we're doing? Actually, we just had a meeting about this last week. Everybody on civil commitment will now be part of a central database that hospitals can look into. But they have to say, I want to look and see if Eleanor's listed there. We don't have a way to get data from them. We only have the opportunity to give them data right now, which is still beneficial because there's certain things that we want them to be aware of if someone's been civilly committed. We don't want them to be allowed to go voluntary, for example. We don't want them to be released until a case manager hooks up with them. We want them to leave with,
if they're
that
already on
connection.
the program.
If they're already in our program, right?
Because
They're in our program.
and that's why you say you don't want them to go voluntary, because they're already on a court order.
Exactly.
So it doesn't make sense. They disappear into the voluntary and then
Exactly.
leave the voluntary without us knowing. Yeah, because our goal obviously has always as well been, and it's I always try to make this clear. If a person can succeed voluntarily, they should succeed voluntarily. You know, without the
Yeah, but we all know the people who voluntarily go in 16 times in, you know,
Yeah,
2-year
right.
period and never really.
It's that
never
zone you're
captures
looking
that.
for, yeah.
Right.
And in Ohio, if you go voluntary, the civil commitment automatically ends. So we can't let them
Correct,
do that.
as with ours.
Is that with yours?
No, it would have to, one order might supersede the other, but
Yeah, well,
it's.
I should correct that,
it's-
yeah.
It stays intact for up to 6 months.
Oh, see, ours doesn't.
For us, if the criteria changed, I misunderstood the question. So if they're on a court order for AOT, but at any point we feel as though, okay, they've gotten to the point that they can do this voluntarily, by law, then the AOT in Texas is supposed to end.
Oh, yeah, these are people who are sneaky. They get picked up by the first responders, taken to the hospital. They start the civil commitment process, and they say, no, I'll stay voluntarily. I mean, we have a number of people in our program now who
Yeah.
did that for years.
I see what you're
Very
talking
high
about, yeah.
users,
Yeah.
very
No, I
high
get it.
users.
I get it. So one of the things I think my biggest mistake was not knowing how to talk to doctors, not knowing how to speak their language, and more importantly, not understanding, because I mean, we're judges, we come in and we want to, we're judges and we come in and we want to be able to say, these are the orders, here's how we want it done, you know, we're going to need them at our courtroom at a certain time and the groups meet at such and such time. And the doctors and the providers aren't used to having courts in their business because it's not a criminal jurisdiction. And if I could do it all over again, I would train a judge to say, look, this is a collaborative effort at the beginning, and you have to understand that it only works because all three providers, doctors, and judges, the legal system, want to make it work. Because if any one of them feel as though they're doing it because they have to, it's going to fail, I think.
I think I would have thought more about housing in the beginning. Housing's a challenge in Nevada. A lot of our group homes closed recently, so we don't have as many group homes. We haven't done great with participants in the homeless shelter. A lot of our participants are transitory, so we don't have local family that they can live with. However, we have had families step forward whose bridges have been burned before, but with the support of AOT has welcomed these individuals back in the home because we have our AOT worker going in and not just supporting the individual, but also the family. So that actually, I think, has been great aspect of the program, but housing is definitely something to think about for these individuals.
Well, we've been fortunate to have a very robust community support service that includes some help with housing. And we have had the collaborative experience of dealing with doctors in some of our other courts. I truly did not appreciate the agnosonomia. I really did not understand that it's so entrenched in the belief system of many of our patients that they are not sick.
And for those who don't know what that is.
Oh, that they don't realize they're sick. That they don't. Part of the illness is that people don't realize that they actually have an illness. And I'm not even sure I said it right, to be honest with you. But I just was surprised by that, because normally in the criminal world or even in mental health courts, you're saying, look, here's the deal. Do you understand? Here's the consequence. Will you take the medicine? I just don't have the same level of ability with this court. And even I had a friend of mine who is schizophrenic, who's been well medicated for a long time, come to visit. And his response was, I just didn't think there'd be that many people who didn't want to take their medicine. So people who are going to do this have to understand you're going to be frustrated because they really, really don't understand that they are sick. And you have to find a way around that for them.
It's more than denial.